Welcome to the Cardio Ohio podcast, a production of the Ohio chapter of the American College of Cardiology. This is Kenny Graywall in Columbus, Ohio.
This is Ben Allencherry, Cardiovascular Imaging Fellow from Cleveland, Ohio. More information on the podcast, including past episodes, is available at ohioacc.org.
And now for today's episode.
All right. Hello and welcome, everyone. This is, I believe, episode 12 of the Cardio Ohio podcast. My voice is obviously new to the first speaker because we've flipped the tables, and Kenny Graywall, who is the co-host of the podcast along with myself, is going to be our guest. Now, before I introduce him as our guest speaker, I want to take time to introduce Andrew Hornick, who will be stepping in Kenny's shoes. Andrew is a cardiology fellow from Ohio State. We did residency together at Case Western. Andrew, why don't you give us a one-liner, introduce ourselves to you and some of your interests.
Hey, thanks, Ben, and thanks, Kenny, for having me on. I'm a second-year fellow at Ohio State. I've got an interest in non-invasive cardiology and hopefully a focus on sports cardiology as well. I was born and raised in the great state of Iowa, but made my way out here for residency in Cleveland, where I met the illustrious Ben Allencherry. So really great to be here with you two tonight.
Awesome. Thanks, Andrew. And before we reintroduce Kenny as the guest, we want to talk about our subject matter. And it's a different sort of subject than we've spoken about before. We're going to talk all things high sensitivity troponin today. And we're going to try to answer some of the common questions that people have. Kenny is a content expert and has dedicated a lot of his research and clinical thoughts to high sensitivity troponin and how it should be rolled out and how it should be used. So first, I want to reintroduce Kenny. Kenny, why don't you just tell us a little bit about how you jumped into the high sensitivity troponin field?
Hey, thank you very much, Ben, and welcome, Andrew. Great to have both of you to chat with. Yeah, this is a little bit different hat for me than my normal hat as the president of the ACC and as a cardiac imager here in Columbus. But I really think this is an important topic. You know, as you may know, Ben, there was just a report in JACC in the last couple of weeks that showed that only about 30% of hospitals in the U.S. have transitioned to high sensitivity troponin assays, even though they've been clinically approved for several years. My interest in this, and this is actually a good lesson for you fellows and other trainees, back in 2017, when the first troponin T assay was about to be approved in the U.S., we were here at Riverside Hospital in Columbus. We were approached by our clinical laboratory team and the lead pathologist about transitioning from the current assay of troponin T over to the fifth generation or high sensitivity assay. They came to one of our department meetings and, of course, were extolling the benefits of higher sensitivity and the results from Europe. And of course, as you can picture, this was a room full of cardiologists. The first reaction was, what the heck are you guys doing? We don't need more sensitivity to our troponin. We don't need more cardiology consults. We don't need more false positive diagnoses. So then I spoke up and I proposed a suggestion. I said, before we transition to this new assay, why don't we study it ourselves in our own patient population? So I suggested that we take the new assay and we run it simultaneous with the existing assay, the fourth generation, on a group of patients, and then look at how it performs clinically in terms of outcomes to help guide how we're going to implement it. And of course, everyone looked at me and said, hey, that's a great idea. Let us know how that works out when you do it. So suddenly I became the physician champion for our transition to high sensitivity troponin. So that's the lesson for you guys, which is if you decide to speak up at a staff department meeting, you may find yourself taking on some new tasks. But nevertheless, we then actually did that. We did a study where we did both assays on the same samples in many thousand patients over a 3-month period. And I presented that research at the ACC meeting at that time, which I think was 2019. And ever since, I've been kind of teaming up with our little team to continue to explore like how the assay is working in terms of delta troponin, accuracy for events, trying to figure out optimal cutoffs, et cetera. So it's been kind of an interesting journey, and we're now several years in and still kind of learning the process. So that's kind of how I came to be a troponin guy.
That's awesome. And I think as a cardiology fellow, certainly from time to time, we've waded through lots and lots of positive troponin consults. I'm curious, I suppose, could you define just for us and for the audience, maybe the definition of a high sensitivity troponin, how that differs from some of the older generation assays?
Yeah, sure. So of course you guys are too young to remember, but there was a time back in the early days where diagnosing myocardial infarction was pretty challenging because we were using multiple biomarkers, things like CPK and LDH, even all kinds of crazy stuff. You would get a panel and it was just this crazy scheme to try to figure out what was positive or not. Troponin came out, I think, in the early 90s. And of course, there's been successive generations of the assay. Just as a reminder to everyone, remember that the troponin complex is unique to heart muscle. And the troponin complex actually has three proteins or subtypes, troponin T, I, and C, but the actual assay for it is based on either troponin T or the troponin I subcomponents. And so subsequent generations have gotten better at detecting the protein. Of course, it's so helpful in cardiology because troponin is almost completely unique to heart muscle. Apparently, there's very, very tiny amounts of troponin T in skeletal muscle, especially when people have skeletal muscle disorders, rhabdomyolysis and some of the inherited muscle diseases. But basically, it's unique to the heart. So any detectable level of troponin pretty much implies cardiac injury, other than the exception of slow clearance, renal disease. Part of the issue with previous versions of troponin, like the existing troponin T that was used previously, is that it didn't pick up low levels very well. So actually the 99th percentile cutoff was actually higher than the detectable cutoff. So basically any detectable level by the assay was considered positive. And that's how we treated troponin in the past. So high sensitivity just refers to the fact that these newer assays can actually detect circulating levels of troponin that are below the 99th percent. In other words, they're quote normal. And if it can do it with a certain accuracy, which we call the coefficient of variation, then that meets the threshold for being called high sensitivity. Now, there is a difference between troponin T and troponin I assays. The troponin I is made by many different companies, and each of the assays that's used for trop I is slightly different because they use different antibodies. These are all antibody assays. So troponin I is in the public domain, so anybody can make an assay for it. So as a result, there's multiple troponin I assays, and they're not interchangeable because they all use slightly different antibodies and different methodologies. Whereas troponin T is proprietary. It's only made by a single vendor, which is Roche from Europe. And so troponin T being proprietary, it's a single assay that's more interchangeable between institutions. Now, we at Riverside use troponin T. I believe you do at the clinic as well. So a lot of institutions do use troponin T, but there are high sensitivity troponin I assays as well. It's just that there's a little bit more variability between those.
We definitely use troponin T. I haven't seen many troponin Is.
But, I think it is certainly the circumstance where every once in a while you will get a patient transferred to our institution who is coming with a different troponin assay in their chart and their lab results.
Exactly. You guys probably see this at your institutions too. You'll see these patients transferred as a quote non-STEMI because of bedside troponin at an outside ED or whatever was elevated. And then of course you repeat the markers at your own institution and they're negative. It's really a problem with older assays with troponin I, especially the bedside ones, because they use a different methodology and there's more cross reaction with other proteins in the blood. At least with the newer generation, whether it's I or T, it is more specific, but of course it's also very sensitive, so you can pick up low levels.
Yeah, and Kenny, that sort of background information is very important. It kind of sets the stage for this, to what you kind of brought up, this higher sensitivity, picking up myocardial damage earlier. Like, what does it mean clinically that you've seen in that we're probably picking up a lot more type 2 MI? And just for the background audience, type 1 we think of as acute plaque rupture or acute coronary syndromes that are occurring. There's primary blockage of the heart artery. Type 2 is more a supply demand problem. And this is me oversimplifying it, but just for a general schematic. Do you think we're picking up more type 2 MI? And in Riverside, as you've seen this being rolled out, how have you navigated that? Like teaching cardiology fellows, helping other practitioners navigate a mildly positive troponin in the wrong clinical setting, in that it's not an acute coronary syndrome?
Well, it's a challenge. Of course, with any test that whatever cutoff you pick as quote abnormal is a trade-off between sensitivity and specificity, and that's the case with troponin. Of course, the forte of the assay is how sensitive it is for very, very low circulating levels. So, of course, you are going to pick up smaller amounts of injury. The important teaching point, though, is that any detectable troponin, especially if you detect a serial change in the levels, is consistent with injury. Even if it's a low level positive, that is cardiac injury occurring. It's just that cardiac injury can occur for lots of different reasons besides obstructive CADs and thrombotic or type 1 MIs, as you alluded to. So the way a couple other things to point out about the assay is each institution does set its own cutoffs. There's some recommended ones from the vendor, but one of the big differences with Trop T, at least, is that there's different cutoffs for men and women. And this is something that they kind of learned in Europe as they were using the assay more widely, is that women who have less overall total myocardial mass will have lower levels of troponin release with injury than men will. So if you have a single cutoff for both sexes, you're going to basically over detect positives in men and under detect them in women. In other words, it's going to be less sensitive in women and a little bit less specific in men. So we at Riverside decided to go with sex specific cutoffs. So we use a cutoff of 22, nanograms per liter in men and 14 in women. I think most institutions do that, but I don't think everyone does. I think there are some who use a single cutoff because it's just easier for clinicians to kind of interpret, but we did go with sex specific cutoff. So that does help a little bit because that helps, pick up fewer false positives in men, and it makes the test a little more sensitive in women. But it's still a trade-off. And as you alluded to, with such a sensitive assay, you are going to have more types of cardiac injury that are due to other causes, including type 2 ischemia, but also, many other things that all of you guys know about as other causes of cardiac injury, like sepsis and pulmonary emboli, other coronary issues like hypertrophy, accelerated hypertension, AFib, RVR. And we do see more of that. There's no doubt about it. Now, one thing we do to try to mitigate that is we report the delta troponin as an actual result with a normal value or abnormal value to help our clinicians. So when people get serial troponin, we actually decided to report the delta troponin as a value, and we arbitrarily have picked 20% as a clinically significant cutoff. And so that helps our clinicians, so that if there's just a flat elevation with a negative delta, the interpretation actually says that this could be chronic injury rather than acute ischemia. So that helps reduce the cardiac testing and hopefully reduce some of the consults we get for elevation. Because as you guys know, you can have flat elevation in a lot of chronic cardiac and non-cardiac conditions. So those are the kind of things we've done to try to kind of find the balance between sensitivity and specificity. But we actually just presented an abstract at the ACC 2 weeks ago, looking at that exact question you asked, Ben, which is how often do you get troponin elevations that are not due to obstructive CAD? And we found that the incidence of MINOCA, which is, myocardial infarction with normal coronaries, was actually about 25% since we've started using HS troponin, whereas in the typical literature, it's, 10% or less. So I think we do have actual evidence that we're seeing a lot more non-ischemic type elevations. But the key is that it really is cardiac injury, and it really indicates a poor prognosis. It just happens to not be due to obstructive disease. So it's still worth diagnosing that injury and using whatever tools you have to exclude obstructive disease.
And before we jump topics real quick, you had said that your hospital provides the delta troponin number. So along with like the second high sensitivity troponin value, it will actually provide the delta. Is that correct?
Yeah. And what we did is we used 20% as what's considered a significant delta, but below 28, which is, we use an absolute change of 7. So our criteria for a positive delta is that it's an absolute change of at least 7 or 20%, whichever is higher. Because obviously, if somebody's troponin goes from 8 to 10, that's a 20% change, but we all know that's not really clinically significant because those are normal levels. So we use a delta for that percent for the higher numbers and do an absolute change below. But we actually do report it. And in our laboratory results, there's actually a little interpretation guide that explains when it's significant or when it's not, to try to hopefully minimize consults.
Yeah, the battle is it's just conveying that new topic, new education to all the providers, because you can't expect like ED providers, general medicine providers to stay up to date on these new literature when even cardiologists sometimes are trying to keep on edge. So that seems like a novel way.
Yeah, absolutely. One of the big roles for us as cardiology consultants, of course, it's easy to sit back and complain about the silly consults and all those things, but educating hospitalists and educating emergency room providers, that's going to fall on us as cardiologists. We're kind of the gatekeepers for these issues. So part of our rollout included a lot of education. And it wasn't just one time, it was ongoing with our hospitalists, our residents, and our ER docs. So that's definitely been a big part of it. And that would have to be a big part of the plan for any institution that's planning to make the transition.
I think along those lines, one of the things that was exciting about high sensitivity troponin at its rollout was its utility to be a rule out test for patients coming to the ED with chest pain. Has your institution, added any sort of risk scores or risk calculators, like, a heart score or something to your algorithm in the ED? And is that something you talk about with the providers, how to use the high sensitivity troponin in addition to those scores?
Yeah, absolutely. In fact, we're big proponents of heart score as well. I like heart score because it's just so simple and it's great for non-cardiologists. Most cardiologists can look at a patient and say, gosh, you have ST depression or you have these risk factors. We know you're elevated risk. It's pretty obvious, but it's not so obvious for hospitalists and ER docs. So the heart score is a great tool because it's so accessible and simple to calculate. So we actually advocate that for every patient, that the troponin be used in conjunction with the heart score. And as you alluded to, Andrew, one of the biggest values of the new assays when it's totally normal, I mean, that is such a low risk patient that you feel very confident that you can discharge them and avoid bringing them in for testing. And that's something the cardiologists don't often see. We see the end result of the ones who get admitted and get the consult. But what we don't realize is, and I didn't realize this till we looked at our own data, but about 90% of chest pain patients in most EDs do get discharged, and having that undetectable trope is like such a confidence boost because the data, the literature shows that that's just an extremely low risk patient. But if you combine it with a low risk heart score, it's even lower risk. But if they're in that low risk heart score group, there's plenty of data showing that like the 30-day event rate is just microscopically low. And so those are the patients you can safely discharge without having to bring in for observation. So I think that's been one of the big benefits. And I think any institution that switches over is going to see that a lot of those low risk admissions start to disappear as you get comfortable with the assay.
I'm curious about how you might approach along those lines in the ED, a patient who comes in with maybe something that sounds like typical chest pain and has a troponin value that is less than that 99th percentile cutoff, but does follow some of the kinetics that might be more classic with, concerning for MI. I think you said your cutoff value is about 22. So maybe their troponin goes from 5 to 20 and then back down to 5 another 3 hours later. Do you have an approach for those patients or kind of a sense for what that might represent?
It's really hard to say. Obviously, that 20 value would be high in a female. It happens to be just below the cutoff for a male. I think when you see that, of course, one of your early questions was how do you balance sensitivity and specificity? Of course, when you're talking about chest patients, we all have to value sensitivity more, right? Because there's such a penalty for missing a myocardial infarction that you probably want to compensate for that in terms of occasionally admitting somebody who turns out to be false positive. So, I think in that kind of situation, you got to err on the side of safety and say, well, even they didn't peak positive, let's look at their heart score. Let's see if their EKG changed at all. If there's any doubt, we'll bring them in for observation and repeat the assay or consider doing a non-invasive test. So I think because we got to err on the side of not missing MIs, we just have to, accept the fact that you're going to occasionally bring in patients that have negative workups. But I mean, that's been the story of chest pain as long as there's been chest pain, which is you don't want to miss the infarctions. And of course, there's other tools like I'm sure you guys use at your institutions that can really help, like CCTA. You can do CCTA directly in the ED, and it's a great tool for these kind of borderline cases that maybe you don't want to necessarily admit or put through a big workup. Because once again, a negative CCTA is almost 100% negative predictive value for disease. So it's such a great tool. Even a calcium score, honestly, there's data that just a negative calcium score alone has predictive value. So I think those are the patients who probably end up needing some of those tools.
And just a quick plug, episode 1 of our podcast talks a little bit about some of these non-invasive imaging modalities. I just wanted to bring us back to, first of all, like back in the day when Andrew was a young intern and I was actually his chief resident, and that might explain some of the negative stuff he's gained. So I apologize, Andrew. But we learned a lot about this thing, unstable angina, which was like the bane of all our existence. When you were the resident overnight and you admit this patient with chest pain and the ED's like, well, he's high risk and, things are negative, but it might just be like, we're not catching it. What do you think? And this is like an existential question now. Do you think unstable angina exists anymore in the era of high sensitivity troponin?
Well, I'm sure you remember that when we talked about unstable angina, whether it was recently or even back in the day, we were probably talking about a group of disorders, right? I mean, you think about the patient that you see in clinic who says, gosh, doc, I've been working out and I get this little tightness in my chest now that I didn't used to get. Maybe it's even a patient with known disease. I mean, a patient like that's not going to have positive cardiac markers, but technically if their chest pain is progressing, then it may be, quote, unstable. And those patients still exist. And of course, a lot of them end up getting stress tests and caths and have obstructive disease and need treatment. In the emergency room setting, though, I think unstable angina has gotten much less because so many of them now turn positive. With HS troponin, at least the troponin T we use, with the old assay, we considered a positive 0.04 or higher, 0.04 nanograms per milliliter. Well, that corresponds to a troponin T of 50. So if you think about it, if you could only detect troponins that were 50 or higher, think about all those non-STEMIs and other ones that we now pick up that we would have labeled unstable angina back in the day. And there's a lot of them. So I think they're transitioning over because of the assay, but it still exists.
Yeah, I think that's a good point. And, one thing we always talk about is that even stable angina, when it first starts, is by definition unstable. So I think it's not just from my experience, it's just because we have these new biomarkers doesn't mean we ignore those patients who are enzyme negative, but have stories that sound somewhat worrisome and they have risk factors. I don't think that's okay. Never see the cardiologist again. It might just be an opportunity for strong primary prevention and close follow-up. Andrew, you want to take us to the next Jack paper?
Yeah, definitely, Ben. And despite what Ben says about our checkered path, he was quite a good chief resident. I got to give him props, I guess, for that, even though he is, a Maryland basketball fan. But I think part of the genesis for this podcast topic was the recent article in Jack, and I think Canny, you touched on how the Ohio Health journey with high sensitivity troponin started, kind of rolling it out in 2019. How did the findings that you all had at your institution compare to, the recent Jack paper? And do you have any comments on sort of the findings in that paper itself?
No, I think it kind of reinforced what a lot of us have seen at institutions that have been using the assay, which is that kind of the fears that it was going to lead to a lot of downstream testing were kind of unfounded. And it's just like what we were talking about before. I think there's the thing about the HS assay is that when it is normal, you just have so much confidence that the patient's low risk and doesn't need immediate testing that as the paper showed, there's actually less testing that gets done. I think it did show that there was a little bit more coronary angiography since the new assay came. And that's probably because you're kind of picking up these low level positives, because I think, there's still a tendency to kind of fall back to angiography when you see an elevation. And that's definitely not the case with this new assay. As over experience and time, we've learned that so many of these low level positives have non-obstructive disease that you can definitely rely on, whether it's nuclear imaging, CCTA, et cetera, to confidently rule out disease without having to go to a cath. So I think that's kind of the lesson from that paper, which is that we still need to reduce the normal cath rate, but it is reassuring. And this is our experience too, that there's not a lot more utilization going on, whether it's, admissions or testing.
And as that utilization kind of gets wider, Kenny, one thing that we've seen is even in patients who have some form of CKD, clearance of this high sensitivity troponin can be delayed, as we know. And do you have any guidance for when consultants call you or primary teams call you about how to interpret high sensitivity troponin in the setting of CKD?
Yeah, I think there's definitely a couple of strategies that help, because it's a very challenging situation. And it's not just even those patients, it's the patients with other chronic disease or critical disease in the units. One strategy is that the delta troponin still applies. So even if you have poor clearance due to renal disease, if there's a peak and a fall in the levels, that's still consistent with acute injury. Now, there's still a differential for that, of course, that we have to think about. But so I think you can rely on the delta a little bit in those patients, number one. And then number two is use a simple non-invasive tool like a bedside echo. And there's a lot of literature showing that the echo is a great stratifying tool. So in patients who have an elevated cardiac marker, if you can document that the EF is globally normal and the wall motion is normal, there's data showing that they have a good prognosis, at least as far as cardiac outcomes. So that's a very helpful bedside tool with really not much of any risk, really, that can stratify those patients and kind of try to sort out which ones really do need further evaluation or not. But no matter what, it's going to be a challenge in most patients, and it's still a challenge with a new assay.
I think that's a great idea, using non-invasive testing like echo to kind of help parse out those sort of patients who, even by nature of having CKD, they're at higher risk of having cardiac events. In that same vein, we, as we were learning like 10, 15 years ago, we sometimes use CKMB, which has fallen out of favor, obviously. The role that we learned it in was reinfarction, where while the troponin T was still on its curve of being eliminated from the body, CKMB might be able to show another peak, so that if you had a reinfarction or an early infarction after, I wanted to ask you, have you heard of any role for high sensitivity troponin in those settings of reinfarction?
Yeah, I think because it is so sensitive to injury, it's more useful than the prior assays in that setting. The usual scenario is somebody who comes in with an MI and has PCI, they go home, and then maybe 5 or 7 days later, they're back in the ER with atypical pain. You're trying to sort out, is there really something new going on? I think in that setting, it is helpful, because even though it may persist for up to 7 to 10 days after an MI, I think you will see a new rise pretty quickly if there's truly stent thrombosis or something like that going on. As far as CPK-MB, I mean, I'll have to be honest, Ben, I think you were probably in grade school last time I ordered a CPK-MB.
I was in diapers.
How to order one, probably.
Which hopefully wasn't grade school.
That was the only biomarker he taught us.
So if there is a utility for CKMB anymore, I'm not that aware of it, but maybe people smarter than me have figured out a way to integrate it in.
Kind of along the lines of, the nuanced uses of the high sensitivity troponin in specific populations. Is this a test that you're ever using in the outpatient setting? Or is there a specific patient, say, or patient population that you might find utility in it?
Yeah, I think very rarely, I would say. I'm sure you guys would agree, but there's an occasional patient you see in clinic where you just park them in the waiting room and send off the Trop T, because luckily we have a lab right in our clinic where I have practice, where we can immediately draw blood work and send it off. I haven't seen much utility in other conditions. Now, of course, there's a lot of literature showing that just even chronic levels of troponin T can predict prognosis. So I think in a lot of conditions, there's literature that it correlates with their prognosis. But in terms of how you apply that to a given patient sitting in front of you, I'm not sure.
Excellent. Thanks. And then I guess one of the points that this paper made and that you touched on earlier in our talk was that still only maybe at 1/3 of hospitals are using the high sensitivity lab tests. Do you think there are specific barriers that are preventing the uptake of this lab specific factors, or is it just kind of, slow rollout and slow adaptation to new evidence?
Yeah, I think some of it's just inertia to change. But as I learned in our rollout, it's a very complicated process to change these assays. It's not the same, as simple as like, oh, we're going to stop using this on December 31st and start using the new one on January 1st. These laboratory systems are so automated that they're $1 million systems, and you just don't change them overnight. So I think there's just there's expense involved, there's education of clinicians, and there's just inertia. Unless you have a physician champion who's kind of understands the literature and the utility, there's just going to be a lot of physicians who are very comfortable with what they already know, and that acts as a sort of resistance. But I think as more and more literature comes out, it's very obvious that, you want to have the best assay. I was at a talk once recently about troponin, and one of the clinicians was talking about how there's a saying that he was using, which is back when troponin was a terrible assay, it was a great test. Now that it's a great assay, it's a terrible test. And I disagree with that. I think that's an old school view of that, but I think it's more of an issue of just understanding how to use it. And I think in that setting, it's clearly helping us triage our patients properly.
Kenny, and I think the only way that statement was true from the speaker was when you're the general cardiology fellow on call and you're not getting paid per consult. Not sure if I'm allowed to say that on air. But so we should wrap up. We are very respectful of all our listeners' times, that this is a around 30-minute podcast. I want to summarize. First, I want to just thank Kenny for changing his hats and being the content expert for this podcast. Do you have any last words for us?
No, I think it was a good discussion, and I thought you guys asked some great questions. And unfortunately, my consult list is getting longer, so I need to get going.
Yeah, that's great. And Andrew might be seeing some of these consults. Thanks a lot, Andrew, for coming on.
Just thanks for letting me join.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.